Okay, and then first and foremost, one thing you want to go over is you want to be safe with everything, not having a needle exposed. So when you are not actually driving, make sure that you cover your needle. Put it like that. That way, when I'm pulling through and I'm wailing here, I'm not going to poke anybody with this. Anytime you're not actually driving, make sure that you cover it. Also, use your instrument, your Adson or your pickups, to manipulate your needle. Don't grab this. Just like you wouldn't grab an injection needle, you wouldn't grab this needle with your finger as much as you can. So try to use your instruments to manipulate your needle. That way you protect yourself, you protect the patient, you protect any assistant working with you. Okay. So as far as suture selection, what you want to look at is you have two different options really. You have chromic gut kind. Those are the kind that are going to dissolve on their own. They are made out of like a biological material, so as soon as they get exposed to body fluids and stuff like that, they're going to start to dissolve within a day or about a week or so. If you're doing something usually extraoral, this is silk suture. Silk suture does not dissolve. You'll have to take that out or do whatever with that. Also, another thing to look at is the size. 3 is the largest size, basically the main one that you'll be using. They make a 4, they make a 5, which is smaller and smaller. 5 is a little small, it can get a little knotty, but you might use it if you're in a really aesthetic zone, like if you've done a frenectomy or something like that. But generally you're going to use 3 because it doesn't break as hard, it's easier to work with, and doesn't knot up on you. Okay, so the first thing to know about this is that it's going to be direct vision only. You're not going to use your mirror, you're not going to work from behind too much. It's always going to be direct vision. So for the most part, you're going to be at 7 o'clock position working with your patient. Second thing to know is you're going to put your ring finger through, you're not going to hold the hemostats like this. You're going to actually hold them like this. This is going to give you stability and control as much as you want, precision-wise, okay? And now as far as ergonomics go, notice that the needle is curved, all right? And so if you're ever working in a place and you're bending too funny or it feels funky on your wrist, you're not doing it right. So there are 6 sextants, remember, we're going to go over. There's only 3 actual positions of the way that you're going to put your needle in, okay? Okay, all right, so for the first sextant, is what you're going to be doing is going to have like an overhand hook like this. This is going to allow you to come in and drive like this. And all you're going to do, because the needle is curved, is you're going to make a rotational thing like that. So you notice first sextant needle is going to be curved, pointing that way like that, okay? All right, so for sextant 2 and 3, what you're actually going to have is you're going to have the needle pointing down and out like that. And the reason why is because you're actually going to work a little bit like this. So it's going to be upside down, and you're going to drive like this all the way. Okay, for sextant 5 and 6, what you're going to do is you're going to have the needle pointed down, but then pointed across your body like this. You can see that. And this is because you're going to come in and you're going to curve, 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 curve. Now once you get to the last sextant, you're not going to be able to work like this, right? Because you're going to run into their tissue. So that is, it's going to be pointed down and curved away from your body. So you'd be able to come in like this, dun, 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 like that, okay? So if you notice, this sextant here and this sextant here have the same exact needle placement, down and away from you, okay? And so 2 quick points about order of how you're going to do this is you're going to always try to go from unattached gingiva to attached gingiva, okay? So 99% of the time, that's going to be from the buccal side to the lingual side, okay? Because often when you do an extraction, what you do is you're going to be pressing and releasing that gingiva on the buccal side, so that's going to be free, unattached. So you're going to manipulate it and hold it in place with your instrument to where you can place it exactly where you need it to be. Same thing on the other side, okay? Second point is that you're always going to try to work, especially if you're running more than one suture, is you're going to run from distal to mesial, not mesial to distal if you're running a length right there. One, that's going to keep you from having to work over what you've done. And then also, if you work distal to mesial, again, at the end, you're going to have obviously less suture to work with. So you're not trying to work with less suture and way, way back in the oral aperture trying to deal with this little thing that you're trying to tie. So you want to be way out here in the front at the very end, end up out there.